now begins our discussion of ischemic heart disease. So ischemic heart disease is a result of defects in cardiac perfusion that is inadequate to meet myocardial oxygen demand. Causes, of course, will either be increased demand or decreased supply, so especially when the heart rates or wall pressure is increased, high demand states, or in setting where you have narrowing or occlusion of arteries secondary to coronary artery disease or spasm, which decreases the supply of oxygen to your myocardium. Risk factors for coronary artery disease should be ingrained in you, especially when you hit the floors. Age. Men are at typically higher risk than women earlier on, so men greater than 45-year-old or older women, postmenopausal women greater than 55 years old. A family history of early coronary artery disease or cerebrovascular disease, smoking, hypertension, hyperlipidemia, diabetes mellitus. Some of these are modifiable and others are non-modifiable. Obviously, you can't choose age or sex or family history, but you can do something about the last four. The pathogenesis of ischemic heart disease includes four types: stable angina, variant angina, unstable or crescendo angina, and myocardial infarction. Stable angina occurs when you have a fixed narrowing of the coronary arteries, usually caused by atherosclerotic plaques. It causes chest pain with exertion when oxygen demand increases, such as during exercise or catecholamine-rich states. It's relieved by rest. In contrast to variant angina that is caused by vasospasm of the coronary arteries, can be idiopathic. Spasm can also be induced by cocaine, which also, in addition to causing vasospasm, can increase oxygen demand and can cause premature atherosclerosis in chronic users. Unstable angina is caused by severe coronary artery disease with transient or non-occlusive thrombosis. It causes sudden cardiac ischemia at the end of the supply line, so to speak, and it is characterized by progression of symptoms over time. So worsening in terms of frequency or severity of the chest pain, so-called crescendo angina, or if you have symptoms at rest, by definition is unstable angina as well. Myocardial infarction is caused by a complete occlusion of a coronary artery. Most common cause is rupture of an atherosclerotic plaque. The exposed endothelium of the ruptured plaque leads to platelet aggregation and thrombus formation, which will completely occlude the artery. Occlusion of the vessel causes transmural ischemia, and within seconds, ATP is depleted. Within minutes, there is a reversible loss of contractility, and within the hour, there is irreversible injury. Reperfusion injury occurs with revascularizations mediated by oxygen-free radicals. That's why it's so important in terms of timing of opening up these vessels with angioplasty or thrombolytics. With regard to anatomy, you have a left and a right coronary artery. The left coronary artery feeds the interior left ventricle and the interventricular septum, in addition to the lateral wall. The right coronary artery feeds usually the posterior heart in addition to the inferior left ventricle, all of the RV, and provides supply to the atrioventricular node as well. Here is a morphological representation of a coronary thrombus, and you can appreciate that there is an area of ruptured plaque, and when the plaque ruptures and the endothelium is exposed, you're able to aggregate platelets and form thrombus and completely occlude the coronary artery, and the territory distal to this occlusion will proceed to go through the aforementioned changes, leading ultimately to scar. So on gross pathology, within 0 to 12 hours, the infarct is usually inapparent. The infarcted areas may appear somewhat pale. However, within 12 to 24 hours, the infarct has a well-delineated yellow-tan appearance. The coagulation necrosis has set in. 10 days to 2 weeks, this pale yellow necrotic area is rimmed by a zone of highly vascular granulation tissue, and then after 2 months, the infarcted tissue is replaced by a white fibrous scar. So on day 1, you have these wavy necrotic fibers. The space between the fibers from myocyte death, and you have normal fibers in the territories surrounded that have different blood supply or not at the end of the supply line, so to speak. On day 3, you get an infiltration of neutrophils. You have necrotic tissue, which initiates an inflammatory response and brings in the inflammatory mediators that attracts these cells. By day 7, you get removal of the necrotic debris by macrophages, and the granulation tissue starts to form with collagen deposition. And at this time, you have a very highly vascularized granulation tissue. However, over time, you lose this vasculature and you increase the fibrous components of this tissue, ultimately leading to scar formation. The clinical pathology of ischemic heart disease includes signs and symptoms of crushing chest pain that radiates to the left arm, jaw, or neck. You have associated shortness of breath and diaphoresis, nausea and vomiting. You can have tachycardia or palpitations, and if severe, you can go into overt cardiogenic shock. Cardiac enzymes are released by the dying cardiac cells. CKMB is elevated by 48 hours and peaks at 18 hours and normalizes in 2 to 3 days. Troponin I is elevated by 3 to 6 hours, peaks at 16, and can stick around for 7 to 10 days. Troponin I is more specific for cardiac disease. And here is a graphical representation of various enzymes that historically have been used to track myocardial infarction, so you can appreciate the initial elevation in myoglobin that quickly falls within 48 hours. CKMB and troponin I, as discussed before, in terms of their peak and duration of circulation. And lastly, you see LDH, which is not a commonly used marker for myocardial infarction, but you can see how it persistently is elevated for some time following infarction. Clinical pathology of MI complications, so sudden death. So the infarcting heart is a very arrhythmogenic substrate. It's the most common cause of death, and it can lead to cardiogenic shock. Other complications include cardiac rupture, which usually occurs in a 3 to 7 day period following an MI. You can rupture the ventricular wall, which leads to tamponade. You can rupture papillary muscle, which can cause, if in the LV, can cause valvular insufficiency of the mitral valve and lead to acute symptoms of shortness of breath and pulmonary edema and a new murmur on exam consistent with MR, which would essentially be holosystolic blowing, heard best at the apex, radiating into the axilla. And there's 2 gross pictures below that demonstrates on the left there ventricular free wall rupture, and on the right the papillary muscle rupture. Also, you can develop congestive heart failure depending on the amount of myocardium that was infarcted from the MI. You can also develop a post-MI pericarditis, which is usually fibrinous in nature. You can develop a mural thrombus if you have significant wall motion abnormalities, which may increase acutely your risk for embolism and stroke. You can also develop ventricular aneurysm, which increases the risk of heart failure from loss of contractile tissue. These ventricular aneurysms can be represented on 12-lead ECG by persistent ST segment elevations following MIs. Treatment for angina is treated by attacking supply and demand. So you increase blood flow with nitrates or calcium channel blockers. You decrease the myocardial oxygen demand with beta blockers. The acute MI is treated with opening up the vessel. You give them antiplatelets such as aspirin, thrombolytics when indicated, such as TPA or streptokinase, or if you're in an institution that provides it, you can do angioplasty with balloon plus minus stent placement. In patients that have 3-vessel coronary disease or left main disease, you can perform coronary artery bypass grafting. So here's a simulated question. The gross appearance of the heart at autopsy from a 65-year-old man with a history of renal failure is remarkable for LVH. What is the most likely underlying condition to explain this finding? Likely this is going to be a concentric or pressure-induced LVH, which most commonly is caused by D, hypertension. In the morning, a 50-year-old male experiences crushing substernal pain, which begins to radiate to his jaw and left arm over the next few hours. The man waits until late afternoon to seek medical attention. The laboratory finding most likely to aid in diagnosis, again, we use CKMB and troponin as our specific enzymes for myocyte death. And so in this circumstance, being several hours, greater than 4 hours after the event, the CKMB is likely to be elevated in this patient's OA. And that concludes our session on ischemic heart disease.